Hello, everybody, and welcome to today's webinar, Share the Risk and Share the Rewards of Partnership, a joint presentation from HealthBegins and Nonprofit Finance Fund with support and close collaboration with the Commonwealth Fund. So I want to say thank you to all of you for joining us today. My name is Dr. Rishi Manchanda. I'm president of HealthBegins, and we'll be joined today by co-presenters Victor Tabbush, adjunct professor emeritus at UCLA Anderson School of Management, Tanya Shah, vice president of delivery system reform from the Commonwealth Fund, and Kristen Giantris, managing director of consulting at Nonprofit Finance Fund. So I want to say thanks to each of you as well. We're going to learn a bit about who is on the line so far as we advance the slide. A recap for those who've registered, and thank you for those who have registered. You may have seen this already in the invitation. The learning objectives that we hope to cover for this webinar are that we hope at the end of this you'll be able to list at least 2 benefits of using the calculator in a way that's relevant for your work in partnerships, whether you're on the healthcare side of a partnership or community-based organization side of a partnership, drawing on experiences in the use of the calculator. We want to make sure that by the end of this, you're able to describe the new version of the calculator, which you're going to hear about shortly, including some really, I think, wonderful new resource materials that are available, and I think are going to advance the whole field. And lastly, we'll hope that you understand how to stay engaged and access upcoming resources related to the calculator. So we'll move to the next slide. This is a brief recap of the agenda for our conversation today. I'll spend a few moments reviewing the goals of the ROI Calculator. We'll then hear about some important features of the calculator, as well as some of those new resources that I alluded to earlier. And then as we turn the baton from Victor and Tanya over to Kristen Giantris, we'll hear about the work ahead and have space at the end for your Q&A before we wrap up. As we move next. I want to remind folks that we ask you to submit your questions and comments via the Q&A pane throughout the webinar. You'll notice in your doc for the GoToWebinar that there is a Q&A section there. So please go ahead and submit your questions or any comments you have throughout this webinar using that function. We'll answer your questions as best as we can during the Q&A portion. Please also continue to stay engaged in our conversation, both today on the webinar as well as afterwards, by using these Twitter handles. At HealthBegins, at NFF_news, and at Commonwealth Fund. So with that, let me go ahead and welcome everybody. This is a brief, if you don't know us already, HealthBegins is an organization that is proud to partner with Nonprofit Finance Fund and the Commonwealth Fund, and what we do in most of our work, including today, is help health systems and their community partners to improve care and social determinants of health. And we have the privilege of working with the whole variety of partners across the country, from designing strategies to implementing strategies to move upstream. But enough about us. Let's move to the next slide here and talk about who really came together for this particular project for the ROI Calculator and the long-term goals of improving partnerships. This was a team effort from HealthBegins, from leaders at the Nonprofit Finance Fund, and of course from the Commonwealth Fund. And without them, without everybody you see on this list, we would not be able to do what we're doing today. So thank you to the project team. Next slide, please. So to get us started, I would like to get a better sense of who you are, because certainly if we're going to advance the understanding of return on investment for these types of partnerships between healthcare and community organizations, we understand your work as well. So go ahead and tell us what best describes your organization. We'll leave this poll open for about 30 seconds. Are you a hospital or healthcare delivery system? Are you with a health insurance plan or managed care organization, a CBO or social service organization, a public health agency or department, or other? Another 15 seconds. I want to make sure everybody has a chance, and let's go ahead and close the poll now and see who we have on the line today. I know we have about 150 people already attending, so let's get a good sense of this as we close the poll out and look at the results. It looks like the results are not being displayed on the screen here, but I'll just read them out based on what we're seeing. So it looks like about 30% of folks are from hospitals or healthcare systems, another 18% are from CBOs, so that seems to be the biggest mix, and then a whopping 45% are other. So perhaps in the Q&A section, for those who marked other, you can share with us more about how you identify your organization. But with a pretty diverse audience here today, let's launch into the conversation and describe really the problem statement, if you will, the challenge that we at the project team certainly understand, and I think many of you resonate with. We know that there is these days a lot of activity to address the so-called social determinants of health, but there are limited tools to support the partnerships that are coming together to address those very issues, especially in sustainable ways. We know that community-based organizations and healthcare organizations need a common platform as they come together in partnerships, a common platform to invest in similar programs to address patients' social needs, if not community-level social determinants. They need a common platform to plan for the future as well. But we know that there are barriers to adoption of these tools, barriers to adopt a common platform, barriers to adopting best business practices. And you can see some of the barriers to adoption listed here, and perhaps some of you have experienced some of these barriers in your own work as you're building these partnerships from healthcare to community or from community to healthcare organizations. So as we move to the next slide, as we understand these long-term goals, just going back to the long-term goals, we wanted to depict what the project team's long-term goals were in terms of thinking about that challenge, and that is first, to come together as a project team to be able to scale the adoption of the ROI calculator, the calculator that first came out from the Commonwealth Fund, putting this wonderful tool online. And what we recognize at HealthBegins and with our partners at Nonprofit Finance Fund, along with the fund, is that this tool was starting to serve as a catalyst. And our goal long-term is to continue to use the calculator as a way to be able to be a catalyst to help strengthen and develop healthcare and community-based organization partnerships. The second long-term goal we have is to make sure that in the process of strengthening partnerships, learning and using the tool as a catalyst, that we're learning how to improve the tool itself in way of furthering these partnerships themselves. And the last long-term goal for the project team was to make sure that we add to the evidence base. And the way that we started to do this in this particular phase of work that we'll hear about shortly as Victor and Tanya speak to this, was to bring together not only advisors who we're really grateful to have both on the line today and who came together in this first phase of work from across the country. But we also brought together leaders who we call super users, those who were particularly motivated and eager to use the ROI calculator in their own context. And with that, I want to be able to give you a brief glimpse of, on the next slide, the super users who we were fortunate enough to be able to recruit and who really volunteered to join this effort. Lee Caswell, VP for Community Health at Presbyterian Healthcare Services, Tracy Johnson, Director of Healthcare Reform Initiatives at Denver Health, Kevin Rice, Director for Research Development at Fountain House in New York, and Leslie Scotland Stewart, Director of Healthcare Innovation at Project Angel Heart. These super users came together in a set of trainings, and we dove through a lot of both technical aspects as well as broader aspects in terms of the business of partnership development between healthcare and community organizations in a in-person training and several TA calls afterwards. And the next slide highlights some of the challenges, just the high-level challenges among the many issues and that the super users and the advisors brought to our attention. But these are the three high-level ones that we wanted to share with you all as part of today's conversation. The first identified challenge that we learned from our work with the super users and with our advisors was that it's difficult to define the business case of partnerships when there's limited data or evidence for return on investment. The second major challenge was that there's a high degree of uncertainty among leaders in both sides of the partnership equation about the potential range of outcomes for the interventions they're looking to pursue in partnership. And the third identified challenge is that there's limited experience or familiarity with different payment systems about how CBOs in particular should be paid for the work that they're doing increasingly in these partnerships. So those are the high-level challenges that we're going to hear folks speak to right now. And the privilege that I have is in being able to now hand the baton over to our presenters. We're joined today, as I mentioned, by Victor Tabbush, Tanya Shah, and Kristen Giantris. It really is a privilege to have worked alongside each of these leaders as well as members of their teams and their respective organizations. And you'll soon find as I turn the baton to our first presenter, Victor Tabbush, you'll see why Victor in particular and every person on this project team was such a vital part of being able to address those challenges that the super users identified. So with that, Victor, we'll turn the baton to you. You can let us know how to advance the slides.
Thank you, Rishi. Hello, everyone. The very first challenge that Dr. Manchanda cited in the forging of these cross-sector partnerships is the uncertainty about their effectiveness, their impact, at least from a financial standpoint. Evidence is really not abundant given the relative newness of such arrangements. Ideally, we would use outcome data stemming from randomized controlled trials to assess the return on investment. That would be the highest evidentiary standard. And should such trials demonstrate statistically their effectiveness, that would constitute proof. An intermediate evidentiary standard is preponderance of evidence, the second P in this diagram. Here, we might use evidence from a post versus pre-enrollment comparison, not quite the gold standard that an RCT is. The evidence might show that utilization diminished over time as expected, and if other studies with similar context and addressing similar populations show equally encouraging, but still not definitive statistically, encouraging results, we might say there is a preponderance of evidence, meaning it is more likely than not that the integration is working or has worked. And indeed, this is the utility of the evidence review, one of the new aspects of the guide that of the calculator that will be referred to later, where a range of outputs or results are available. But what happens if there is only slim evidence or none at all? Then we can resort to that third P, plausibility. Now, plausibility means that intuition and informed judgment suggests that the financial returns are indeed attractive. And here is where a feature in the tool can help you make a plausible case that integrated systems of care may make economic sense. Let's go to the next slide. So look for the feature in the menu bar under optional tools, discovering utilization changes. Essentially, the feature works to mirror financial break-even analysis. The user specifies an ROI threshold for the health system partner that must be crossed for the partnership to be deemed attractive. And then the calculator shows just how effective the partnership must be in order to attain that ROI. Let's go to the next slide. This is a screenshot that displays the result from conducting threshold analysis. The user, you, set the target, in this instance, in this example, cost neutrality, an ROI of 0%, but of course you could put in any ROI target you wish, and then the tool shows what is the necessary effectiveness in terms of lower readmissions, ED visits, or lower skilled nursing admissions in order to get there, to achieve that goal. In this example, I have chosen reducing readmissions as the path to achieving that goal, and the calculator has told me that a 9.6% reduction will accomplish that. Here is where plausibility comes in. Often the expenses of the medical events are so large that even a minor reduction in them will achieve the target. Intuition and judgment alone about effectiveness might be sufficient to at least encourage the partnership. There is another use for the threshold feature, and that is during the planning phase of a new initiative, say a pilot. The result of the threshold analysis can help you identify specific and measurable objectives, which after all is good practice in project planning. Let's move to the next slide. The prior feature is especially helpful when you have little or no data concerning evidence. Another challenge to overcome is when evidence concerning outcomes is mixed, or indeed when evidence concerning costs is mixed. When there are multiple relevant studies, each of which reports somewhat different numbers. The user would like to know which number is the best one to use, the most accurate one to input into the calculator. It's not always possible, nor is it necessary due to deploying the simulation feature the second optional tool in the calculator. Here's how it works. The user chooses a most likely value for each variable that can influence the ROI, but there is uncertainty around their true values. So the user selects the width of the uncertainty band around each variable. The tool then simulates this uncertainty and reports not a single ROI, but rather a range of its probable values. The tool can then tell you, if you wish, what the probability is that the ROI will not achieve a critical minimum level, say break even. You may discover that even with the inherent variance and uncertainty, you can have statistical confidence that a particular ROI will be in fact achieved. Next slide. The third challenge for partnerships is how the CBO partner is to be paid, under what payment system, and at what level. Next slide. There are 5 distinct payment systems that are modeled in the calculator that can be used to reimburse the community-based organization. First of all, full cost recovery, where the CBO receives payments that equate to its cost. Secondly, fee for service, where a payment is made for each unit of service. Thirdly, a case rate, where a CBO receives payments to provide a specified service for a given period of time. Next, capitation. CBO would receive a per member per month payment to provide an array of social services. And finally, gain sharing, where the CBO receives a combination of fee-for-service payments and a share of any financial gains. Now, partnerships are inherently risky financially. The returns are uncertain as they depend on many unknowns. That risk is unavoidable. The only question is how the risk is to be shared between the partners. For example, where the payment system to be one where the CBO recovers its full cost, the CBO assumes no cost risk. Instead, the health system partner assumes it all. At the other end of the risk spectrum is a capitated system where the CBO assumes full cost risk and the health sector partner assumes none. The other systems in between are more balanced in their division of cost risk. And gain sharing is unique among the payment systems in that it puts the CBO at risk for effectiveness as well as costs. Next slide, please. The payment question involves not just choosing the method of payment, but also its level. The system determines the division of risk. The level determines the division of returns. The calculator prompts the user to select both and then displays the projected returns in terms of an ROI, percentage-wise, and also in terms of a per member per month net income. And it does so for both parties, that is the health sector partner and the CBO, as we see here in this hypothetical example. The outputs displayed here, along with the prior risk simulation, therefore provide an array of financial options that can be examined, and one can be selected to govern the cross-sector partnership, one that is mutually advantageous and meets the financial needs of both parties. So that's a short tour around some of the new features of the calculator and how some of the difficulties or challenges that Dr. Manchanda had cited can be overcome. And I wish to thank the Commonwealth Fund and especially Tanya Shah for providing the financial, intellectual, and administrative support to make this tool possible. Over to you, Tanya.
Thank you, Victor. Hi, everyone. This is Tanya Shah. And I wanted to step back for a minute because this has been a little bit of a journey for the Commonwealth Fund along with our partners that are all on the phone. And I wanted to share what we have heard from users as we pilot tested the features of this ROI calculator over the course of 2017 and 2018. Next slide, please. So what we heard when we launched the pilot version over a year ago, and we collected feedback very purposefully through user focus groups, but also through direct communication with users in order to identify what could improve this set of resources, we heard kind of 3 big things. We heard that this was useful. This approach, this tool was useful in addressing a gap in the field that helps both CBOs and healthcare organizations jointly plan and set goals as it relates to meeting social needs of people that they serve. So that was good. That was some positive feedback. But what we also heard about the tool was that it was overwhelming, and that a lot of organizations did not have the data to generate a meaningful ROI estimate, and that they needed help. They wanted some support in doing this type of business case planning and this type of scenario planning. Next slide, please. And so the new version incorporates this user feedback, and we hope it includes better guidance documents and a more user-friendly interface. Some of the key information resources actually just live on the welcome page. Some of you may have already visited the tool, but they are all hyperlinked in the welcome page. And I do want to mention that that's where you can spend a little bit of time and get oriented to all the pieces that you need to maximize the utility of the ROI calculator. These resources include definitions of the social determinants focused interventions that the calculator is geared towards helping identify the return on investment for. Pre-work on data that you will need to bring to the calculator in order to maximize its utility. Where healthcare costs and utilization baseline data is missing, we provide some national estimates to guide inputs necessary for ROI calculations, an evidence review, which I will go into in more detail, and an overview of the calculations behind the calculator. Next slide, please. So where we spent a fair amount of time leveraging experts in the field, as well as doing a lot of digging on promising and emerging evidence around social determinants, is captured in this evidence review. Rigorous studies that look at health utilization and cost impact of interventions that address social needs is very limited. Many of you know that. There's still a lot of work to do in this area, and the Commonwealth Fund is supporting that, but we are a little bit behind in this particular area of health services research. However, what we did find is that there are positive and promising research, both in the peer-reviewed literature and in the gray literature, and we tried to synthesize that specifically with an eye towards answering some of the parameters that you need to input into this calculator. As I mentioned, there are limitations on what is available, and the purpose of this guide is really to help in input values and generating ROI scenarios, but it is not a replacement for your own patient, client, or program data. That is a limitation of the tool. It is garbage in, garbage out. So it is best to use your own data, and in the absence of having data, we have created what we have found available in the public domain around some of the variables that are important for these calculations. Next slide, please. So the evidence review is organized by social determinant category. We took each category and provided a summary of the findings, and then we listed and linked roughly around 10 to 15 studies in each category that we thought were useful to users. We broke it down into which population they focused on. We provided a description of the intervention, the strength and type of evidence, whether it was a randomized control trial or an observational study. We tried to get the cost of the social service intervention. This was actually quite a hard category to address, and Kristen will be talking more about this in her section. And then we summarized the quantified impact on utilization and cost of care where available. So I do think that this in itself is a little bit of a useful orientation if you are at the stage of just deciding where and which social determinant to address for which subsegment of your population. This is a good place to kind of see where some of that value has been realized. Next slide, please. Another area that we found, especially among CBOs who are trying to generate the business case, that a lot of people didn't have their hands on cost and utilization data from a healthcare standpoint. And so we created, based on the variables that the calculator asks for, some national estimates on high need, high cost populations, what have been some of the key cost and utilization data based on nationally available studies. And so that is also summarized in absence of that data being available. I just wanted to say that I hope these types of resources will help fill some of the information gaps users are facing and encourage some of that meaningful partnership discussion, scenario planning, so that community-based organizations and healthcare organizations can come together to mutually design and decide on organizational goals so that we see these types of efforts scale to sustainability. We welcome, this is a living, breathing body of work, and we welcome constructive feedback. It's a continuous improvement effort. The data that you're putting in, the ROIs that you're generating, we would love to hear how that process is going. What are some of the challenges? Where can we be more helpful? And in order to continue to improve upon these set of resources, I'm going to turn it over to our next presenter, Kristen Giantris, who will discuss our efforts to assist users moving forward.
Thank you very much, Tanya, and hello to everybody. We are all really excited to be engaged in this work, and I'm excited to be able to introduce you to the next phase of the enabling and advancing the role of the calculator in partnerships. If I could have the next slide, please. In phase 2, we are very much building on the learnings and the direct user experiences of phase 1. And again, this is all in the aim to advance the use of the calculator across the field. So our first goal is really to increase adoption of the calculator going forward as a key tool and enabler of partnership contracts. So we're moving from the idea of how do partnerships come together to how do they actually get contracted. We are specifically looking to support and capture how these partnerships are negotiated and then sustainably contracted, and the useful role that the calculator can play in building out these contracts. Secondly, we want to continue to appeal and reach out to broader audiences as we are doing today, and so that we can really engage as many leaders in possible in including the calculator in their own exploration and assessment of partnerships. So we're going to look to focus on network structures where we can reach multiple individual organizations, as well as leverage a network infrastructure to spread the opportunities and use of the calculator. Lastly, we're going to be intentionally looking to pull out of the work that we're doing key data on interventions themselves, and really direct experiences with the partnership contracting exercises and efforts that we're seeing in the work with the participants during phase 2. And again, we are going to look to share all of this information very widely and as transparently as possible so that we can support others who are pursuing these paths and seed sort of interest and broader use of the calculator most broadly. So next slide, please. As we look forward with this work, we're looking to engage participants in various ways over the next 12 to 18 months. First, we're going to be identifying 2 active partnerships with support from an established advisory committee and the super users who were engaged to date under the first phase of this work. And we're in identifying these partnerships, we are looking for Nonprofit Finance Fund and HealthBegins to be able to provide very tailored consulting and technical assistance to be able to move those 2 active partnerships to actual contracts, and contracts that are really models for others in the field. We'll also be creating a learning collaborative that will focus on an established CBO network where partnerships with healthcare is a priority for this network and for its members, and where we can introduce and or amplify the use of the calculator to as many individual members within the network as possible, but also move the larger network with some education and training towards sort of the more viable partnerships with various healthcare organizations in which they may already be engaged. Lastly, we're going to be looking to actively share out all that is learned and creating ways to engage and interact with both the calculator and what we're learning from it. So we're going to have instances where we'll build greater knowledge and connection to many of you. And we'll be looking to dig into and hold up a number of technical issues to be addressed and areas of applied work from CBO cost of services and pricing exercises to healthcare utilization rates, ultimately to sustainable payment models. Next slide, please. As Tanya noted earlier, one of the critical elements and inputs to this calculator and to its successful use is really on what are the costs of the services being delivered by community-based organizations. So how do we determine those service unit costs? And we have been exploring this already in phase 1 of our work with a number of our super user partnerships. And I think if you have worked with the calculator at all, or if you have been in any discussions with partners from either the healthcare side or the community-based organization world, I'm sure you're quickly getting to this question of what does it cost for CBOs to provide service, and how do we know how that's going to impact utilization rates? And it may be, on the face of it, seemingly a direct, a straightforward question, this eye of, so what does it cost to deliver these services? But in reality, it's quite hard to unpack. And I just wanted to briefly offer the perspective on this slide and on the next slide on an approach about how to determine these costs. First, I just want to highlight one thing, that many of these community-based organizations do not currently operate at a pure unit cost level. And there are some, but not all, who can easily pull apart a clean and allocated cost center number. But when we actually ask to go down to a unit cost level, it becomes very, very challenging in the current structure. And so what we have found is that if we ask people to start where they have a better handle on cost, that's usually at an enterprise level, then we are able to sort of deconstruct those costs down to the unit level, which are necessary to be able to do this calculation of return on investment. So we're going to go deeply into this kind of work in phase 2. We're going to be able to share methodology and financial models to the field on how to make these kinds of assessments and calculations. And on the next slide, I just wanted to give a little bit of a preview on what some of that can look like for your use going forward. There are several tools that we're going to be launching soon to the field on how to look at the cost of service calculation. And I'm just highlighting something on this slide here, which is a screenshot from a recently developed cost of service calculator. And it really walks through the cost analysis process I described in theory on the previous slide and models out how the specific unit costs can be based on various cost allocation methodologies and therefore used in conversations and calculations with healthcare partners on getting to an appropriate ROI. So this tool is coming. This tool with a supportive user guide will be released soon. We're also going to be releasing 2 other cost assessment tools, our full cost workbook and our cost allocation tool. And I think these tools are really just one way that we want to stay engaged with you and supporting the broader field as we look to enable the use of the ROI calculator more broadly. So if we turn to the next slide, just want to be able to talk a little bit more about how we really would hope to stay engaged with you going forward. So I've already highlighted on the previous slide our cost of service tools. There will be other tools and guidance made available. We'll be looking to share information on partner assessment and readiness tools, on payment model tools that address appropriate pricing ranges and hopefully by issue area, and then on best practices around contract terms and conditions as we move further in our work in getting to actionable contracts between healthcare organizations and community-based organizations. We're going to look to bring this work also to life through various use cases, and we'll highlight those on a number of different webinars along with other learnings. We will be active on the conference circuit, so we are really looking to spread not just spread the word, but really engage in dialogue directly with many different participants and stakeholders through being present on panels and in different discussions in different conferences and convenings, some of which we're already booking and confirming, and others which we'll be working on over the next year or so and be putting out to this larger community. Lastly, and as was already referenced earlier, we really want to be able to continue to hear and learn from you, and whatever your direct experiences are with the ROI calculator. As Tanya said, this is a living and breathing piece of work, and it only remains relevant insofar that we get the feedback from those of you who are really the early users and adopters, and making the improvements that you point us to along the way. So we are looking to make available to this group and broadly speaking, an online function by which you can share direct feedback on your use with the calculator, and we'll get word to you about that following our webinar. Needless to say, we're really excited about the next phase of work and engaging as many participants as possible in it. And we really would love to hear from you right now on your observations and questions to date on the work and the tool and how we'll be moving forward. So I'll turn it back to Rishi, who's going to take us into a Q&A session.
Kristen, thank you. Tanya, thank you as well. And Victor, thank you. For each of our presenters, it's really been a privilege to work alongside you. And as I think you'll all agree in the audience for this, a lot of wonderful information that's shared. Let's open this up now to really take some of your questions. I remind you again to submit your questions and comments via the Q&A pane. We already have some great questions coming in. To tee us off, though, I wanted to turn the first question actually over to someone who has been deeply engaged in this process. I alluded earlier to the super users who were engaged in the first phase of this work. And I want to ask Leslie Scotland-Stewart from Project Angel Heart, if you could unmute yourself and maybe take the first question to be able to share your experience when it comes to the use of the tool and your participation in this first phase of work. What was it like for you to be able to look at this tool, and how are you using this tool in the context of your work?
Yeah, absolutely. Thank you, Rishi. And it's been a really exciting process to be able to see the evolution of this tool and all the improvements that have been made. I'm with a community-based organization that provides medically tailored meals. We have been contracting with a local managed care organization to provide meals for dual eligible patients. That contract's been going on for about a year and a half. And I would say for the first year, we were super excited and were able to build up referrals. And then sort of after a change in guard, those referrals fell off rather quickly. I was able to use this tool to engage with a researcher, which is Dr. Tracy, and be able to engage her with, can we start to formulate the members that we have served meals to and start to see how those members and those costs have been impacted. And that really piqued her interest because she's in the process of working to prove the various social determinants of health and their use within her healthcare facility. And just having such a robust tool that truly was able to output some numbers and some ROI really allowed us to have a robust conversation. So we're hoping that this data will then help us to, again, build referrals and get the program nice and solid and successful again. I would say the other two just quick additions to that would be, number one, if you can do it alongside in some way your healthcare partner or your potential healthcare partner, it allows you to find common language. So I think one of the challenges as a community-based organization is truly understanding your healthcare partner's needs and pain points, and even just different terminologies that they might use, within their organization. So bringing us both to this tool really helped me learn more about this healthcare provider and, their different methods of operations and different things like that. And then finally, I think that it allows us to potentially request larger projects and more additional funding. We plan to use this ROI calculator as a case study to go to other healthcare partners and say, we were able to prove ROI with this particular partner, and hopefully, continue to acquire more contracts through healthcare partners. So I hope that was helpful.
Leslie, absolutely. And if you'd humor me, I wanted to take the first question that's come in from the audience and maybe turn it to you to take the first pass, and then I'll turn it over to Kristen to add on. One of the questions, there's a lot of great questions coming in, so again, keep them coming, please, in the Q&A pane. One of the questions is about the process that you kind of referenced just now in terms of your recommendations. And one of the questions from Bilal Taylor is, who needs to be on the team to be able to participate in the ROI process, and what's the time frame that you would recommend in terms of how to sit together and estimate the ROI calculation for a particular intervention? Leslie, do you have any thoughts about who has to be on the team and how much time to allocate to participate in this process?
Yes, that's a really good question. And I would say ideally, obviously, you want to start this conversation with the calculator before you even enter into the contract. But we sort of did it after the fact in order to sort of re-engage the contract. I would say build in, in between each discussion that we have, there tends to be at least a couple of weeks of just people getting their regular to-do list done. So I would say build in at least a couple of months to go through this process, just because people get busy, stuff gets put on the back burner. I would say at least a couple of months. And as far as the right people at the table, you want somebody that has the power for a long-term financial decision within that organization. One thing that I found is oftentimes the individuals that are able to approve a small pilot program are different than the individuals that are able to put a larger scale program in an operations budget. So, if you're discussing a pilot program, you always want to have the question, which is, what are we trying to achieve, and how would we fund that if we are able to prove in this pilot program that it works? And I think with that question, you can start to discover, who the decision makers are to get programs at a larger scale with these different healthcare partners.
Leslie, it's a wonderful answer, and I'll turn it over to Kristen to see if you have additional thoughts on the same questions. Who needs to be on the team, and what would you recommend to CBOs and their healthcare partners in terms of the time it takes to go through this process?
Sure. No, great. I think Leslie's answers are extremely helpful. In terms of I'll take your last question there, Rishi, in terms of the time that it takes to go through the process. I think it's a very solid point Leslie makes, that it takes time to sort of gear up for this. I would also say, I would say I think it also differs depending on how prepared you are coming into the conversations. I'm going to I expect in Leslie's case, because they were already sort of active with a contract, that they had done a lot of their behind the scenes work as a provider, and particularly back to those earlier topics I was covering around determining costs and unit costs. Depending on how much readiness has been done particularly on the side of the CBO before coming into this conversation, will really drive the timeline. I would highly recommend that CBO, before they start the conversations, bring together their leadership team, bring together their CEO or CFO or a finance director. If the service is coming out of a very particular program within that organization, the program director who really knows what it means to implement and deliver, and really do their work ahead of starting the conversations. And that is even 2 steps before starting the effort of using the calculator, but do the work of trying to make sure that there is an understanding of what are the drivers of costs, and what are the considerations that they want to highlight to their healthcare partner on what it takes to deliver this service. And then in terms of who needs to be on the team, I think from the CBO side, I've sort of articulated that. I do think that it is often a bit of a black box for CBOs to understand when they come to the healthcare partner that entity to them is not always, it's not always discernible who they are actually talking to or should be talking to. So that idea of, is this a pilot how does it get funded, where does that come out from the healthcare organization, versus are we looking to make a long-term sustained financial agreement here? Those are two really different conversations, and I would say that it really therefore depends on what you're trying to structure and who actually holds power and decision making on the healthcare side.
Krishna, thank you so much for that, and Leslie as well. I want to pivot to some of the technical questions, and I'm going to group them together. First technical question that many in the audience have asked is, will the slides be available? The answer to that is pretty straightforward. The answer is yes. All those who've registered, including those, of course, who are attending, will receive the link to the recording after this presentation. The other technical question is about the tool itself. Victor, and I wanted to ask you if you could speak to two related questions. One is, does the tool allow for the entry of minimum and maximum estimates for certain components? That's a question from John Shaw. And the other related question, if you wouldn't mind addressing it as well, is a question related to the multiple causes. And I'm looking for David Aylward's question, which is, how do you address multiple causes? In other words, when there are multiple interventions from a CBO, and how do you account for the fact that there may be multiple interventions that a CBO is offering to be able to lead to one common goal? So, Victor, defer to you in terms of how you like to take on one or both of those technical questions.
Well, let me take on the more straightforward one. At least the answer is pretty straightforward, and that's yes. There are two ways to, if you wish to deal with minimum and maximum values, there are two ways to do it. You can use the simulation feature, where you essentially are inputting into the calculator a triangular distribution. At one end of the triangle, the left end is the low number, and at the high end of the triangle, or the right end, the right side of the triangle is the high end, and the peak of the triangle is the most likely estimate. And so that's one way to do it. Otherwise, a little bit more complicated way of doing it, you could just run the calculator twice, create two different scenarios, save them, and then make a comparison between them. So the first time you make your entries, make them pessimistic or low, and well, optimistic if you're putting in costs and you put low numbers. But you know what I mean. You can have a pessimistic scenario and an optimistic scenario, and then put them side by side. So those are the two ways to do it. The other question is one that always comes up, and that is attribution as opposed to contribution. If you're doing multiple things simultaneously, how do you know which particular prong of a multi-pronged approach is responsible for the results? And short of a controlled experiment where everything is held the same except one piece of the intervention, one prong of the intervention differs, there really is no way to parse it statistically. Rishi, I ask you or Tanya, others to provide their views on that second, more difficult question.
Yeah, I think you've answered it, and I think there's a lot more that will come through the use of the tool, as we've found from the experience of super users. Leslie, did you have additional thoughts on that? I do have a couple of other questions that I wanted to flag, but we'll turn it to you to see if you have additional thoughts about that idea of multiple. How did you reconcile the fact that Project Angel Heart provides multiple services, and as you tried to demonstrate their business case?
We didn't, again, with this one being after the fact, where the service was actually already set in stone, we didn't play with that too much. I'm working on another contract right now, though, where we are sort of playing with that a little bit, so I may have more to report out at a later date.
Yeah, no worries. It's a great question. I think as Victor and Leslie you're speaking to, it's a question that does vary based on the unique circumstances. There's another question that goes to the tool itself, and then I want to broaden the aperture a little bit back to some of the higher level questions that are coming through as well, beyond the technical features of the tool. But the one last technical question, Victor. is about the outcomes that are used or that can be used for the tool. So the question coming in is, are there only 3 outcomes that you can utilize in the calculator: ED visits, readmissions, and SNF admissions as well? Or are there other outcomes to choose from that have associated costs, as this questioner is asking, such as developing diabetes or having a preterm birth, et cetera? Can you speak to that briefly?
Yes. There are a multitude of outcomes that can be modeled and are modeled in the calculator. For example, outpatient visits, imaging, pharmacy, on and on it goes. There is, in addition to admissions, there is the length of stay of an admission. There is a menu of maybe 10 different outcome areas that you can consider in assessing the results. In the threshold analysis, which I demonstrated today, the threshold analysis is limited to looking at the requisite reductions in one of those 3 areas, rather than looking at reductions that are conceivable in all of the other 7 or so. Finally, I might mention there's an open field where you can put in, you can identify the outcome area that is of interest to you. If it's not in the menu, it's under other, and you name it, and you can follow it all the way through the calculator.
That's great, Victor. Thank you for that. Let me pivot now to those broader context questions that are coming through. And Tanya, I'd like to engage you to think through some of these, and they're quite intriguing questions here. One of them is there a role, and what is your sense of the role of government in being able to help, for instance, in bringing some more transparency to this and supporting this type of rate setting, as the questioner is asking. So I'll broaden a little bit more and just say, given the fund's longstanding interest in this space, and as you look ahead, what do you think the role of government is in local municipalities, or more broadly, in terms of this field?
Well, I think the short answer is kind of, 2 key roles. One is to create the payment flexibilities that allow for funds to flow through to meet the needs, meet the social needs of the patients that are, when we talk about complex patients, they tend to be funded through public programs. And so making flexibilities available so that these types of interventions can be financially sustainable. I think that's one key role. The other one is to actually help create the evidence base, because as they create these flexibilities, these flexibilities are already in play, and there are already experiments going on around the country. So North Carolina is a really good example, and helping to kind of bring together those types of coalitions where we can actually learn what are the costs of providing some of these interventions and what are the impacts, how does it actually affect at a state or local level, the braided funding that we're trying to create in this country to support these efforts. So I think there's definitely a role for government at every level that we can think of, federal, state, local, to participate both in generating the evidence, generating the pilots and the really useful information to support scale and spread, but also creating the levers and the flexibilities to let us braid this type of funding.
Tanya, thank you for that. And I wanted to take with that kind of the wonderful answers to this question at a high level of the role of government, whether it's at the federal or state level. Look at the level of the organizations now involved, the healthcare and the CBO partners that have really been the target for a lot of this work and for the project team, and ask a couple of other questions that have come up. There's one in particular that I know each person on the project team on this call in particular has been thinking a lot about. And that is the question from, I believe it's David Elward again. Does it help to get both sides to be transparent, i.e. hospital and CBO share their relevant costs with each other, and how can this be encouraged? I know, had conversations with advisory committee inputs as well as from the super users themselves. Each of you have your respective experiences about this conundrum of the transparency of cost data on both sides of the house. Tanya, could you speak to that a little bit as well in terms of how you've surfaced it, and maybe we can turn it over to Kristen and Victor and Leslie just to comment if you have thoughts.
Yeah, no, I think Kristen and Victor will have some substantive thoughts on this, but I think that that is the name of the game here. I think we are trying to create a tool that builds that trust and creates some of that transparency. And it is true that it needs to go both ways. I think part of the issue is that on both sides of the equation, a accurate and thorough answer on costs has been actually tougher to get to than many imagined. And so even CBOs have a tough time articulating their fully loaded costs, and health systems have a tough time with, charges versus reimbursement versus spend. So it's a complicated issue, and I think the tool is in part designed to encourage that transparency and that trust so that there can actually be this mutually advantageous sharing of both risk and reward. But I will turn it over to Kristen and Victor that have worked kind of more frontline on this specific issue.
Okay, Tanya, I'll respond. My experience has been that in many instances, far too many, there's a reluctance on the part of the health system to divulge the financial impact of having social services provided within an arrangement. Because in many instances, not surprisingly, the returns are very handsome. And if the CBO were to realize the impact, very significant financial impact it is having, they would presumably request a fee which is commensurate with the value they're delivering. And so that's one observation. What I suggest is that a serious consideration be given to a gain sharing system, because if there is gain sharing, then there is a responsibility on the part of both partners. Certainly the health sector partner has to divulge the utilization changes that stem from the provision of the social services, since it's going to trigger the payment to the CBO based on effectiveness. So gain sharing, I think, creates a need for the transparency, and it's a really good system because it does align incentives perfectly, whereas all of the other systems are not perfectly aligned in terms of economic incentives.
Thanks, Victor. This is Kristen, just to follow up a little bit more on that and maybe add one other perspective here to complement what's been said. I also agree on the transparency, and I think it divulges realities on both sides of the table, quite honestly, and Victor's highlighted one around gains that are realized, and we have all talked about this idea of gain sharing and aligning of incentives, so I concur there. I also think that the nature of how the CBOs come into the conversations is very, very widely varied. It's very, very widely varied. You will have organizations who have the ability to either articulate these costs better and articulate them in a more fully loaded, as Tanya said, or full cost way, as the language we tend to use, and therefore are already starting from a better position in terms of transparency. I think though the reality is more CBOs are coming to the conversation, and when they are transparent, they're transparent with numbers that actually aren't fully reflective of their costs, and so they're all of a sudden starting a negotiation from a disadvantage, or they're anchoring themselves in actually a non-realistic and actually not factual place, because as I said earlier, the idea of a unit cost is not something that they actually manage too often, and that is because, back to the other question around government, the role of government is significant in terms of contracting to CBOs, yet those contracts are very, very different in terms of how they are negotiated and structured. So we're at time, Rishi. I
Thanks,
understand.
Kristen.
So,
yep.
yeah, so I just think there is a lot to be learned in transparency, but also openness to understanding how each side are coming to the table.
Kristen, thanks for that, and thanks to each of our presenters today, and to each of you for tuning in. We are at time. As we go to the next slide, I want to be really mindful of thanking all of you. Reminder to complete the follow-up survey you get and to stay engaged in this process. Many of you have asked questions about how to receive additional support and technical assistance. We'll be following up with you, as well as providing information in the near future about how you can learn more about the tool and how to receive support in the context of your work. Follow us on Twitter, as we mentioned before, and a big shout out, last slide, to our advisory committee members, each of whom is listed here, in our profound gratitude to you, to everybody who's joined today in our project team. This tool is meant to be a catalyst for greater transparency, for greater trust, and as the process already is demonstrating for the project team and for hopefully all of you who've been following along, it's already starting to do that. We look forward to staying engaged with you as we go into the next phase of work. Thank you so much, and we'll see you online and in future conversations.